You can see the screen. Hi. Have you read first stent, chemo, and radiotherapy? Risk factor for nasopharyngeal carcinoma, male gender, genetic factor, male gender, genetic factor, family history, and ethnicity. Ethnicity, China, Singapore, Vietnam, and Malaysia. Ethnicity and race, common in China, Singapore, Vietnam, and Malaysia. Again, male gender, genetic factor, family history. male, male gender, genetic factor, family history, and ethnicity common in China, Singapore, Vietnam, Malaysia, and modifiable infection by Epstein-Barr virus, tobacco smoking, and diet consumption of salted fish. Consumption of salted fish. Okay. Diet consumption of salted fish containing carcinogenic volatile nitrosamines. Again, non-modifiable and modifiable. Non-modifiable is the genetic factor, family history, male gender, and ethnicity, like Malaysia, Southern China, Vietnam, and Singapore. Modifiable infection by Epstein-Barr virus, smoking, and consumption of diet, consumption of salted fish containing carcinogenic volatile nitrosamine. And define carcinoma. Carcinoma is a type of cancer that develops from the. It is a type of cancer that it is a type of cancer that develops from epithelial cell. It is a type of cancer that develops from epithelial cell and spread by lymphatics. You can ask the question, so it will be hello. Okay, okay, okay. Then I'm continuing. Once it is ready, then you can start reading question. So, define carcinoma. Carcinoma is a type of cancer that develops from the epithelial cell. Differential diagnosis. Differential diagnosis. Tumor like lymphoma, angiofibroma, rhabdomyosarcoma. Lymphoma, mm, LRA. Lymphoma, rhabdomyosarcoma, and angiofibroma. Lymphoma, rhabdomyosarcoma, angiofibroma. Lymphoma, rhabdomyosarcoma, angiofibroma. Lymphoma, rhabdomyosarcoma, angiofibroma. Lymphoma, rhabdomyosarcoma, angiosarcoma. Lymphoma, rhabdomyosarcoma, angiofibroma. Lymphoma, rhabdomyosarcoma, angiofibroma. Lymphoma, rhabdomyosarcoma, angiofibroma, and adenoid hypertrophy, then infection in adenoid hypertrophy, infection and hematoma, adenoid hypertrophy, infection, hematoma, adenoid hypertrophy, infection, hematoma. What are the differential diagnosis? Tumor, like lymphoma, rhabdomyosarcoma, angiofibroma, adenoid hypertrophy, infection, abscess, and hematoma. What are other non-epithelial tumor can be here? That is lymphoma, angiofibroma, rhabdomyosarcoma. Lymphoma, which type? Non-Hodgkin's lymphoma. Lymphoma, rhabdomyosarcoma, angiofibroma. If palpable lymph node, how to assess? If palpable lymph node, how to assess? If palpable lymph node, how to assess? We will do fine middle aspiration cytology, then may need to do for excisional biopsy. FNAC and excisional biopsy. FNAC and excisional biopsy. FNAC excisional biopsy. FNAC excisional biopsy. FNAC excisional biopsy. FNAC excisional biopsy. I will start by FNAC and excisional biopsy. Start by FNAC and excisional biopsy. What is cytology versus histology? Cytology is the study of the cellular structure and function. Histology is the study of tissue under the microscope. Cytology is the study of cellular structure. Cytology is the study of cellular structure under microscope, and histology is the study of the tissue. Histology is the study of the tissue under microscope. Hyphae. What do you think? It is fungal infection. Fungal infection mainly candida. Fungal infection mainly candida. Pattern of spread, lymphatic spread, lymphatic spread, and local invasion. Pattern of spread, lymphatic spread, and local invasion. Pattern of spread, lymphatic spread, and local invasion. Explain the local invasion. Explain the local invasion. Explain the local invasion. So it was nice actually in that picture. Nasopharyngeal carcinoma. Hmm? You got your file? Yeah, with my Word file hang. You can see on the screen. You can see anything? Hmm. The file became. Okay. If it goes up, then it will go sphenoid sinus and cavernous sinus. Sphenoid sinus, cavernous sinus. Sphenoid sinus, cavernous sinus. Down will come tonsillar pillar or oropharynx and cervical one vertebra. Cavernous sinus, sphenoidal sinus. Cavernous sinus, sphenoidal sinus down cervical one vertebra and oropharynx. Cervical one vertebra and oropharynx. Cervical one vertebra and oropharynx. In the back, base of the skull and flavus. 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 In the front, nasal cavity and paranasal sinus. Nasal cavity, paranasal sinus, orbital invasion. Nasal cavity, paranasal sinus, orbital invasion, and lateral pharyngeal space, medullary cavity. Pharyngeal space, medullary cavity. Pharyngeal space, medullary cavity. Still now not opening. Okay. So local inhibition again, if it goes up, it will go uh, sphenoidal sinus, and mm, cavernous sinus. In the down, cervical one vertebra and oropharynx. In the front, paranasal sinus and orbital invasion. In the back base of the skull, the lateral uh, middle ear cavity. Okay. Uh, if the patient has infection and the swab shows fungal infection. Uh, yeah. Yes, yes. For this patient, diabetes, immunocompression due to chemotherapy, and dead tissue from the pharynx due to radiotherapy, ulceration, which is more prone to the fungal infection. One, diabetic immunosuppression due to chemotherapy and dead tissue from the pharynx due to radiotherapy and ulceration, which is more prone to fungal infection. Direct action and indirect action. Directly, it damages the DNA directly it deliver high energy to the tumor's DNA, causing direct damage to the DNA, and indirectly by generating free radicals, which causes further cell damage. Uh, Okay, the tumor first grow in its then it penetrate to the surrounding tissue, then it go through the lymphatic and embolize there, and then the tumor grow in the node by detecting antigen antibody recognition. It is a pathological laboratory procedure to perform rapid microscopic analysis of a specimen. Frozen section steps. Okay, the surgeon cut a small piece from the suspected growth of the tumor and send it in the pathologist, and micropathologist frozen it, section it, and cut it, then stain it and examine it under the microscope. And once the report is ready, inform the surgeon over phone by telephone. By telephone. Okay, appendicular carcinoid detected. It is a slow-growing type of neuroendocrine tumor originating from the neuroendocrine system. It is a slow-growing type. Carcinoid is a slow-growing type of neuroendocrine tumor originating from the neuroendocrine system. It is a slow-growing type of neuroendocrine tumor originating from the neuroendocrine system. Uh, Carcinoid most commonly found in the small intestine, appendix in the terminal third, rectum, stomach, and lung. Small intestine, appendix, rectum, stomach, and lung. Small intestine, terminal third of the appendix, then rectum, stomach, and lung. uh, in chromogranin A in blood, chromogranin B by immunohistochemistry, and 5-hydroxy indole acetic acid in 24-hour urine. It, it, it releases histamine, serotonin, bradykinin, teikinin, substance P, and prostaglandin. Histamine, serotonin, bradykinin, teikinin, substance P, and prostaglandin. Histamine, serotonin, bradykinin, prostaglandin, substance P, teikinin. Histamine, serotonin, bradykinin, prostaglandin, substance P, and teikinin. In carcinoid, enterochromaffin cell in the crypts of liver cone. Enterochromaffin cell in the crypts of liver cone. Enterochromaffin cell in the crypts of liver cone. Um, when it is metastasized pass through the liver before it reaches to the rest of the body, the liver has these substances can more easily reach the tissue where they can produce their symptoms. Uh, Carcinoid tumor, they will have periodic abdominal pain, manifestation of the carcinoid syndrome, cutaneous flushing, diarrhea, asthma-like syndrome, and cardiac manifestation, valvular heart disease, fibrosis of the endocardium, periodical abdominal pain, cutaneous flushing, diarrhea, periodical abdominal pain, cutaneous flushing, diarrhea, asthma-like symptom, and cardiac manifestation like valvular heart lesion, fibrosis of the endocardium. Most common metastatic site liver. It is the antibodies are usually linked together in the antibodies are usually linked to an enzyme or a fluorescent dye. When these antibodies are bind to the antigen, then the enzyme or dye is activated, and then the antigen can be seen under the microscope. Is detect a certain antigen. Pathology. Chromogranin detection of chromogranin B. Pseudomembranous colitis, suspected sign and symptom, abdominal pain, diarrhea, and fever. Abdominal pain, diarrhea, fever. After consultation, okay. Abdominal pain, diarrhea, bloody diarrhea, and fever. Okay. Only test to detect is the colonoscopy with biopsy. Other test to diagnose is serology test like ELISA. Worm from nematode family. It is a pinworm from nematode family. The patient has iron deficiency due to the affection of the liver by the worm. The iron is stored in the liver in the form of ferritin. So, as it is affected, he needs supplementary iron. Middle-aged man with right iliac pain. Surgery was done. Revealed diabetic. Revealed dilated appendix. Looks like a mass. Histopathology revealed appendicular abscess plus 6 centimeter appendicular mass involving the mucosa and the muscularis layer. As it involved the muscularis, then it is T2, but no lymph node, no metastasis, so NXMX. Um, if it is antispasmodic and uh, um, eh, if the patient is, if not improving with the symptomatic management, then we'll go for surgery. If size less than 2 centimeter, appendectomy. If more than 2 centimeter, then right hemicolectomy with lymph node and ileocholic anastomosis. Again, if the tumor is symptomatic, then conservative treatment initially with antidiarrheal and antispasmodic, and if it not improves, then can go for surgery. If carcinoid size less than 2 centimeter, then appendectomy. If more than 2 centimeter, right hemicolectomy with lymph node or ileocholic anastomosis. Characterized by inflammatory process confined to the mucosa and always involve the rectum. It is a chronic inflammatory disease involving all part of the colon, characterized by inflammatory process. Rectum. It is a chronic inflammatory disease involving all part of the colon, characterized by inflammatory process confined within the mucosa and always involve the rectum. Hmm. Almost idiopathic, but other causes like environmental, genetic, and immunological. Rectum. Involvement of the terminal ileum due to long-standing ulcerative colitis without no escalation. We will offer her total proctocolectomy with end ileostomy because whole colon is susceptible. TNM metastasis, then it will come M1, microscopic with Langerhans cells, non-causating granuloma with Langerhans cells, non-causating colonoscopy finding in ulcerative colitis, there will be extensive ulceration with pseudopolyp, extensive ulceration pseudopolyp and contact bleeding. Extensive ulceration pseudopolyp and contact bleeding. Extensive ulceration pseudopolyp and contact bleeding. In cones, cobblestone appearance, linear fissure, and in cones cobblestone appearance, linear fissure, aphthoid ulceration, thickened bowel wall. In cones, cobblestone appearance, thickened bowel wall, aphthoid ulceration, linear fissure. ulcerative colitis Ulcerative colitis, there will be crampy abdominal pain, bloody diarrhea, tenesmus, and bleeding for rectum with extra-intestinal manifestation. Crampy abdominal pain, bloody diarrhea, then bleeding for rectum, and tenesmus, extra-intestinal manifestation. Complication: patient may develop toxic megacolon, intestinal obstruction, perforation, sepsis, then malabsorption, colon cancer. Toxic megacolon, megacolon, cancer colon, malabsorption, intestinal obstruction, fistula formation, and abscess. Because of malabsorption and increased mortality and infection. Maybe it is relapse, malabsorption, and short bowel syndrome. Relapse, relapse, malabsorption, and short bowel syndrome. Corns more susceptible to renal stone due to malabsorption. There is increased abdominal fat, and this binds with the calcium and leaving oxalates. There will be hyperoxaluria. Okay, in IBD in the skin, there will be erythema nodule. Liver, there will be sclerosing cholangitis. In the eye, iritis, conjunctivitis, episcleritis, uveitis. In the joint, arthritis, other clubbing, arthritic ulceration. Uh, skin, eye, liver, joint, and other. Yes, your friend is joining. Your study partner. Manifestation will be in the skin. In the skin there will be pyoderma gangrenosum. Pyoderma gangrenosum. If you, no, previous one again. Uh, extra intestinal manifestation of the. This is Crohn's disease, ulcerative colitis. In the skin, there will be pyoderma gangrenosum, erythema nodosum, eye, iritis, conjunctivitis, episcleritis, anterior uveitis in the liver, sclerosing cholangitis, joint arthritis, others clubbing, and aphthous ulcer. Is arthritis. Investigation for ulcerative colitis, we will do full blood count. There will be megalobemia in the stool for fecal calprotectin and occult blood test. Barium follow through X-ray and CT. Barium follow through X-ray and CT, and prothrombin concentration to detect vitamin K deficiency, and colonoscopy, but not in acute phase. Okay, so I will say we will do a total blood count. There will be megaloblastic anemia. We will do stool analysis for fecal calprotectin and focal blood test. We will do uh, X-ray abdominal X-ray and the CT, and prothrombin time to detect vitamin K dependent clotting factor deficiency. And once the patient is stable, then we can go for colonoscopy with biopsy. Vitamin, 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 vitamin. Vitamin, vitamin A, D, E, K, and B12. No, short form we cannot say as like a name, not like a word. Yes, for the risk of colon cancer. Treatment of Crohn's disease, mainly medical. First, we will advise the patient about the disease and lifestyle modification. Dietary control should take low residual diet and high fiber containing diet. Advice can refer to gastroenterology and can start some medicine like steroid and antibiotics according to the trust policy and microbiologist. 5 aminosalicylic acid and immunomodulators. And if medical treatment fail and resistant case, then we can go for surgical correction. Again, initially, first we can ulcerative colitis. Initially, we start the patient by counseling, lifestyle modification, food diet modification, that is low residual diet and fiber containing diet, should avoid the fat containing diet, and can advise for the gastroenterologist to start some medication like steroid, and if infection, then we can start antibiotic and antispasmodic. Then 5 aminosalicylic acid and immunomodulators. And if medical treatment fails and patient still have the complaints, then can go for surgical correction. Refractory to medical management and complication like intestinal obstruction, toxic megacolon, perforation, abscess, hemorrhage, cancer. Refractory disease, intestinal obstruction, toxic megacolon, abscess, fistula formation, hemorrhage, and cancer. Yes. It is a pro-inflammatory cytokine which is released from the macrophage and involved in systemic inflammation and is making up the acute phase reaction. Why you are laughing? No, no. TNF activates macrophage and neutrophil. It acts as a cofactor for the T cell. It activates macrophage and neutrophil cofactor in activation of the T cell and mediators in the blood, mediators in the body response in gram-negative septicemia. Anti-tumor effect, similar interleukin-1 effect. It activates macrophage and neutrophil. It acts as a cofactor in activation of the T cell. So two things activate. One is activated of the macrophage and neutrophil and cofactor in activation of the T cell. It has function like interleukin 1 and it has anti-tumor effect mediators the body's mediators to body's response to gram-negative septicemia. Activate macrophage and neutrophil cofactor in activation of the T cell mediators to the body's response to gram-negative septicemia, anti-tumor effect, and a similar effect to interleukin 1. TNF TNF increase the junction permeability. So there is luminal influx of the bacteria, which activates the innate and adaptive immune response. TNF causes increase the tight junction permeability. So there will be a luminal influx of the bacteria. Imatinib, adalimumab, and cetrolizumab. Infliximab. I will not say this one. Satralizumab. Satralizil. Satralizil carcinoma. Imatinib, not imatinib, infliximab, and cetrolizumab. No, this EDA, I will not say. Infliximab and cetrolizumab. Okay, they are, okay, they are monoclonal immunoglobulin G antibody to TNF alpha. They are monoclonal immunoglobulin. They are monoclonal immunoglobulin G. They are monoclonal immunoglobulin G antibody. They are monoclonal immunoglobulin G antibody to TNF alpha, blocking the inflammatory process. They are monoclonal. They are monoclonal. They are monoclonal immunoglobulin G TNF alpha. They are monoclonal. Okay. They are monoclonal immunoglobulin G TNF alpha, and they block the inflammatory process responsible for the condition. Okay, they are monoclonal immunoglobulin G antibody. They are monoclonal immunoglobulin G antibody to TNF alpha, and they block the inflammatory process. Refractory to medical management in ulcerative colitis and for the treatment of extraintestinal manifestation. Refractory to medical management of ulcerative colitis and for the treatment of extraintestinal manifestation. Okay, this is cobalt stone, like the stone, the rock, and linear fissure, then stricture. This is all of Crohn's disease feature. Hmm. Okay, you are discussing the result of a colonoscopy with a young lady. She is very concerned because her father died of colon cancer at young age. Multiple polyps that is variable in size. Multiple polyp that is variable in size. Familial adenomatous polyposis. They can be present in the stomach and in the duodenum. FAP is a autosomal dominant condition which is characterized as a loss of APC tumor suppressor gene in the long arm of the chromosome 5 with the development of hundreds of tubular adenoma and 100% risk of cancer at the age of 40. It is a autosomal dominant condition due to loss of APC tumor suppressor gene on the long arm of the chromosome 5 and leading to development of 100 tubular adenoma with 100% risk of cancer at the age of 40. It negatively regulates WNT pathway. Finish. Yes, other genetic inherited colon cancer is Lynch syndrome, Pitt-Seeger syndrome, Cowden syndrome. Non-neoplastic and neoplastic. Non-neoplastic hematomatous, pseudopolyp, and metaplastic. Hematomatous, pseudopolyp, hematomatous, pseudopolyp, and metaplastic. And neoplastic is villus, tubulus, and tubulovillus. Hematomatous polyp is Pitt-Seeger syndrome. What happened? Hydrogen stop. In your place, still it is sun is there. Okay, this is Egyptian rule, like B to P and P to B. It is a focal or multifocal malformation composed of haphazardly arranged of different amount of tissue that are normally present in the organ. This is a focal hematoma. Hematoma is a focal or multifocal arrangement of haphazardly arranged different amount of tissue that are normally present in the organ, like Pitt-Seeger syndrome. Complication of hematoma. Hematoma they can transfer into malignancy. Malignant transformation, intestinal obstruction, intersusception, ulceration, bleeding, and electrolyte disturbance like hypokalemia. Malignant transformation, intestinal obstruction, malignant transformation, hematoma. What may cause hematoma? Malignant transformation, intersusception, intestinal obstruction, ulceration, bleeding, and electrolyte imbalance like hypokalemia. If hematoma is if adenoma villus type, it has 40% risk of malignancy and diameter. If less than 1 centimeter, 5% risk. Diameter 2 centimeter, 40% risk, 20% risk. Diameter less than 1 centimeter, diameter less than 1 centimeter, diameter less than 1 centimeter have 5% risk and diameter 2 centimeter has 20% risk. And degree of dysplasia. So again, villus adenoma, villus type of adenoma, 40% risk of malignancy, and diameter of the adenoma less than 1 centimeter, 5% risk. Diameter 2 centimeter, 20% risk, and degree of dysplasia. Okay. Hyperplasia due to loss of APC gene. Dysplasia due to KRAS proto-oncogene mutation, and adenocarcinoma due to loss of P53 tumor suppressor gene. Again, sequence of events, the molecular transfer of the adenoma. Hyperplasia due to loss of APC, hyperplasia due to loss of APC tumor suppressor gene. Then dysplasia due to KRAS gene mutation, loss of APC gene, and KRAS mutation, and loss of P53 gene. So two loss and one mutation. A loss of P53. This is a tumor suppressor gene. Tumor suppressor gene. These are the normal. APC gene and P53 gene. These are the normal in all cells. It will be there. Okay. So loss of P53 gene, KRAS mutation, and there is one question. Two hit hypothesis. We say is that to become any cell to be cancerous, uh, the cells both tumor suppressor gene must be mutated. So here is that both tumor suppressor gene. One is APC gene, another one P53 gene. Okay. So again, hyperplasia due to loss of APC gene, then dysplasia due to KRAS mutation, and adenocarcinoma due to loss of P53 tumor suppressor gene. It is a normal cellular gene whose product promotes cell proliferation. Proto-oncogene PPP. Proto-oncogene, it is a normal cellular gene whose product promotes cell proliferation. It is a overexpressed or mutated proto-oncogene that functions autonomously. It is a mutated. Okay. It is a mutated or overexpressed proto-oncogene who functions autonomously. And tumor suppressor gene. This is the normal gene whose absence may lead to cancer development. Hyperplasia, dysplasia, and adenocarcinoma. Hyperplasia, it was hyperplasia, and adenocarcinoma. Hyperplasia, loss of FC, dysplasia, KRAS, and adenocarcinoma, loss of P53. Hmm? Hmm? Okay. These are the gene whose absence can lead to. Uh, mhm. Hmm. KRAS is a gene which gives signal to produce protein called KRAS, and that protein release signal from outside of the cell into the nucleus of the cell, and it gives instruction the cell to proliferate or differentiate. Again, KRAS is a gene that provides instruction to make a protein like KRAS. Then this protein release signal from outside of the cell to the cell nucleus, and these signals instruct the cell to proliferate or differentiate. Okay, this is KRAS. P53. P53 it arrests the growth of the cell at G1 phase. It causes DNA repair and apoptosis. Arrest the growth of a cell at G1 phase, DNA repair and apoptosis. Arrest the growth of a cell at G1 phase, which prevent the replication of the damaged DNA. Okay, it arrests the growth of a cell at G1, which prevents the replication of the damaged DNA, DNA repairs, and apoptosis. Gardner syndrome is the combination of mandibular osteoma, sebaceous cyst, and desmoid tumor. Mandibular osteoma, sebaceous cyst, desmoid tumor, and gastric fundal polyp. Gastric fundal polyp. Yes, Charcot's syndrome, which increase the brain tumor. For FAP, we can do subtotal colectomy with ileorectal anastomosis, subtotal colectomy with subtotal colectomy with ileorectal anastomosis, or ileostomy, or panproctocolectomy with the end ileostomy. It is in another way. In other part, we studied it like this. If it is non-emergency, we can go for subtotal colectomy with ileoanal, ileoanal, or ileo here rectal, ileorectal, rectal actually, ileorectal anastomosis. Subtotal, if it is non-emergency case, if it is a routine case, then we can go subtotal colectomy with ileo. Uh, Rectal anastomosis or ileostomy. And if it is emergency, then we can go for panproctocolectomy with end ileostomy. Hmm. Okay. Uh, at the age of 25 year or even before. So, okay, high fiber diet, low residual diet, high fiber diet, and decreased fat intake, smoking cessation, and stop alcohol. High fiber diet, low fat intake, stop smoking, stop alcohol. She need to do genetic counseling and screening. Then need to start coronal sigmoidoscopy at the age of 13 to 15 up to age 20, and after 20 annual colonoscopy. To 15 up to 20. Endometriosis is presence of ectopic uterine tissue, endometrial tissue other than uterus. No. A 74-year-old patient with diabetes, hypertension underwent cholecystectomy for cholecystitis, and at operation, the gallbladder was found to be thickened and fixed to the liver. Gallbladder carcinoma, gallbladder carcinoma, gallstone. Gallstone. Gallstone is more than 70. Gallstone is more than 70 year female sex. Obesity, smoking, gallbladder polyp more than 1 centimeter, porcelain gallbladder, and family history. Gallstone. Gallstone is more than 70. Family history. Porcelain gallbladder. Gallbladder polyp more than 1 centimeter. Family history, smoking, obesity. In liver, area number 4 and 5. Segment 4 and 5. and then lymph node and portal then to lymph node and portal adenocarcinoma. Local sepsis most likely to be bacteria. If you want break your smelly discharge, it is local sepsis most likely to be bacteria. Local sepsis, Staphylococcus aureus. I will do. I will open the wound. Will take a swab for culture and sensitivity. Then I will clean the wound and allow drainage. I will open the wound. I will take culture and sensitivity. I will do the drainage. I will clean the wound and I will keep it open. Allow drainage. Clean the wound and allow drainage. Few days later, the patient's condition deteriorates with high fever, tachycardia, and the wound and the surrounding local tissue became very congested with purple discoloration and tissue necrosis. This necrotizing fasciitis. Staphylococcus aureus, Staphylococcus pyogen, Bacteroides fragilis, and Clostridium perfringens. Clinically, okay, clinically by cellulitis crepitus, fever, tachycardia, cellulitis crepitus, fever, tachycardia, and laboratory tests increase CRP, WBC count, and hemoglobin decrease, creatinine and glucose increase. Pathological change, extensive necrosis, and with thrombosis of the blood vessel. Extensive necrosis with thrombosis of the blood vessel. Extensive necrosis with thrombosis of the blood vessel. Tissue layer, skin and subcutaneous tissue and the fascia, but spare the muscle. Skin, subcutaneous tissue and the fascia, but spare the muscle layer. Necrotism fasciitis is a critically ill patient, so I will manage the patient according to care of critically ill surgical patient. I will send the patient to ITU after discussing with consultant and ITU registrar. Will send on baseline investigation and after discussing with the microbiologist and checking hospital policy, we'll start broad spectrum antibiotic and I will take swab for culture and sensitivity and after ITU specialist, plastic surgeon, bloody diarrhea, bloody bloody diarrhea, pseudomembranous colitis, hospital acquired infection like gastroenteritis and inflammatory bowel syndrome, ischemic colitis. Pseudomembranous colitis, hospital acquired infective gastroenteritis by norovirus, and ischemic colitis, inflammatory bowel disease. Multiple yellowish plaque with congested mucosa in between, which resembles pseudomembranous colitis by Clostridium difficile. Multiple yellowish plaque multiple yellowish plaque with red congested mucosa in between, resembles pseudomembranous colitis caused by Clostridium difficile. Okay. If patient is treated with a long-term broad spectrum antibiotic, there will be pseudomembranous colitis growth, and it releases the toxin which disrupts the epithelial function. and the exudate of the protein and the inflammatory cells. Pseudomonas colitis is often triggered by the antibiotic therapy that disrupts the normal microbacteria and allows Clostridium difficile to colonize and grow. The organism releases toxins that disrupts the epithelial function. The organism releases toxins that disrupts the epithelial function, resulting in exudation of the protein and inflammatory cell. Exudation of protein and inflammatory cell. Okay. Uh, if it was a hospitalized patient and treated with long-term broad-spectrum antibiotic, old patient now presented with diarrhea with abdominal pain and fever, I will suspect this is a pseudomembranous colitis by Clostridium difficile. We will confirm. Initially, we will do some blood investigation, CBC, CRP, urea electrolyte, and stool analysis. Also, ELISA for toxin A and B, ELISA for toxins, and PCR. And if the patient is stable, we can go for colonoscopy. Colonoscopy is the confirmatory test. We will stop the ongoing antibiotic and according to patient's severity, if first line of antibiotic will be uh, oral vancomycin, second line will be fidaxomicin. If there is any contraindication, then we can go for metronidazole. And if the patient is in fulminant condition, then we can admit the patient for IV metronidazole and oral vancomycin 500 milligram, and we continue the treatment for 10 days. How to detect severe clostridial infection? If the patient is hypertension, WBC count more than 15,000 and 15,000, CRP constantly raised, tachycardia, fever more than 38, and hemodynamically unstable. Wait. We have started from nasopharyngeal carcinoma, carcinoid tumor, inflammatory bowel disease, familial adenomatous polyposis, gallbladder, cancer, pseudomonas colitis. Okay. 22 station still pending. I mean, remaining. Just 5 minute break. After 5 minutes, we'll start again. Okay. I will cut the link and I will send the new link, or you will stay. Yeah, this connection is okay. We can keep the station, and after 5 minutes again we can join. Okay. Yeah. What you will do now? Hmm? Yes.